Hi guys, my name is Arun Samuel Jaykumar and I'm a physiotherapist in the UK. I have a special interest in treating running related injuries, particularly in middle and long distance runners. This podcast has been put together with the help of Rahul Aluwalia, the head physiotherapist for Maharashtra Cricket Association in India, and my colleague Bhavna Chawla, who works as a physiotherapist with me here in the UK. We have tried to cover a whole range of topics, including running trainers, assessment of a runner, as well as rehabilitation of a runner. I hope you enjoy the podcast. Thank you.
Good evening, guys. Welcome to the podcast. So let me introduce myself first. I'm Rahul Aluwalia. I'm a sports physiotherapist based in Pune, India, and I'm the head physiotherapist for Ranji Trophy team of Maharashtra. And we are going to be having a chat with Arun Samuel Jaykumar, and this is going to be a three-way podcast where the initial half is going to be between me and Arun Jaykumar, and the latter half is going to be taken over by Bhavna. Arun Samuel Jaykumar is clinical lead physiotherapist and advanced physiotherapy practitioner from Kent in the UK. And we're going to be talking to him regarding running related injuries for the next 1 hour. Arun teaches workshop with the title Treating a Runner in UK, and he also recently had his workshop in Pune, India in the month of September. And it was a huge success, which left most of the participants asking for a 2-day workshop instead of one. Could you please introduce yourself, Arun?
Hi Rahul, thanks for having me. Great opportunity to speak to everybody about a thing that I'm quite passionate about. Firstly, I have to thank you for hosting the workshop in Pune, and that was amazing, great experience for me, and it was great to see the amount of interest that there was. So much gratitude to you for organizing it beautifully. As far as my introduction is concerned, I am a clinical lead physiotherapist. I have a team of about 23 to 24 physios in my team, and I also work in what's known as a triage service, which basically allows me to have access to referring patients on for MRI scans, bone scans, and I also, within that capacity, I also do some soft tissue and joint injections. So that's a part of my job, but the fun bit for me is to is working with runners and doing most of the physiotherapy rehabilitation stuff, and I've had the opportunity to work with runners for the last sort of 6 to 7 years at multiple different levels, but of course running is no longer just a elite sport. The participation is so big in general public all over the world. So there you go. That's what I do, and that's what I do on a daily basis.
Great. So before we get into specifics on this, can you please tell us, Arun, how your journey all began?
Yeah, so sort of a quick flashback for me. About 8 years ago, when I was doing some private work in a clinic based here in Kent, a running coach came to see me one morning, and he came with a issue with his knee. At the time, I wasn't particularly familiar with running related injuries or anything specific in relation to that, and he had a unique sense of motivation, determination, and drive to get better and get back to running at the time. And the long and the short of it is that I managed to get him better and discharged him. Now that was great, but all of a sudden I started getting a lot of runners that he went and started referring for various injuries. I could no longer just plead ignorance and carry on. I had to sort of pick my game up, and obviously went on a journey of trying to learn from various experts around the world. Some of the people that I would mention, certainly will need to mention here, are people like Dr. Rich Willie from the States, and Tom Goom, who's a UK-based physio who's also done some great work in this area. Another person that I also follow is Binoy Matthews, who's another person in this context that I tend to sort of get information from. So yeah, that sent me off on this journey to learn more and get a bit more knowledge, and thankfully the experience that I've had over the last several years of working with runners has helped improve my understanding. And these guys are fairly unique in that if you are going to ask a runner to stop, even temporarily, you better have a really good reason for it, because they don't usually like being told to stop running. So you've got to be able to explain yourself well. And more often than not, in most conditions, you can ask them to continue with running alongside you continuing with your rehabilitation. So yeah, I mean, that's how my journey started.
Right. That sounds really interesting, Arun. Could you please tell us what are the most common injuries that you see in your runners?
Yeah. So experientially, I'd say patellofemoral joint pain is the most common injuries that I tend to see in runners. But it also depends on the level of experience. So medial tibial stress syndrome is an injury that is fairly common in novice runners, and I do tend to see a fair amount of that. Other conditions like iliotibial band syndrome, and things like tendinopathy, so Achilles tendinopathy primarily, gluteal tendinopathy as well, plantar fasciopathy. So these are some of the conditions that I tend to see in the runners.
All right. Thanks, Arun, very much. I'm going to be leaving the conversation right now. I'm going to pass it over to Bhavna from here. Over to you, Bhavna.
Hi guys, I'm Bhavna, and as Rahul has mentioned, I'm going to jump in and ask Arun a few questions. I'm a physio as well, and I work with Arun in the UK. If we go on to the next question, so Arun, how would you go about your assessment of a runner?
Hi Bhavna, thank you very much for joining us on the podcast. It's a pleasure to have you here. If we start with the history, in particular the injury history, is there a history of bone stress injuries in this individual? And the reason I'm particularly interested in bone stress injuries is there's a high rate of reoccurrence in people who've already had a bone stress injury in the past. And it could also mean that there are other metabolic reasons as to why this individual is predisposed towards developing bone stress injuries. So I would certainly like to ask about that. I would also like to find out more about the running habits of this individual, and in particular, the amount of mileage they do on a weekly basis. I also want to know how they keep a track on this. Usually most runners will have some kind of a GPS device, either a watch or an app that they use to track their distances. And that's very important, and I try and keep things as objective as possible. I also want to know if they've introduced any speed work in the recent past, and that can also predispose one towards an injury if it's a new type of a load for that individual. So those are the couple of things that I want to know with the history.
Right. Is there anything you would specifically ask based on the age of the runner that you're seeing?
That's a very good question, Bhavna. Yes. If I'm seeing a masters runner, so that is a runner who's on the other side of 40, so over 40 years of age. I certainly want to know if there is a diagnosis of osteoarthritis in that individual, in particular if I'm treating the knee or the hip. Mind you, just because somebody's been given a diagnosis of osteoarthritis, I wouldn't ask them to stop running because there just isn't enough evidence to ask somebody to stop. The progression of osteoarthritis appears no worse when you compare runners to non-runners. But I definitely want to know if people have had ACL tears, or that particular runner has had ACL tears or ACL ruptures, or even in fact if they've had any arthroscopy procedures in the knee, because these things seem to influence osteoarthritis more than running itself. So yeah, I want to know things like that, in particular with masters runners. The other thing that I also will keep in mind, and certainly would mention on this podcast, is that if you're treating a masters runner, they are more predisposed towards developing soft tissue injuries. So things like calf injuries, repeated calf injuries, calf strains, also things like tendinopathy, those kind of injuries are more common in masters runners. And there's several reasons for that. Some of them are biomechanical reasons, so reduction in concentric muscle strength in the plantar flexors of the ankle, reduction in muscle girth after the age of 40, and also things like reduced leg stiffness, which is also associated with development of a tendinopathy in the Achilles in particular. So these are things that I would certainly keep in mind.
Right. I noticed you didn't mention anything about their running shoes. Do you not ask about this? Is it important for you?
Yeah, I mean, that is a very contentious topic, really. So the thing is, most runners believe that their runners are really important. And so they will tell you before you ask them any specific questions about a trainer that they wear or the running shoe that they wear. I could even mention a particular study that was done in Holland recently, literally a couple of months ago. So they did a survey amongst over 1,000 experienced runners there. And they asked them questions on what they felt was most important in preventing running-related injuries. And 75% of them believed that running trainers are important in terms of preventing running injuries. Now that's great, but unfortunately the evidence out there does not support this kind of a thinking. No, for me, I would certainly take the information that they give me about the trainers that they wear. I wouldn't challenge them. I wouldn't give them this evidence that I've just mentioned here about this 75% and all of this sort of business. It may not feature very highly in terms of why they developed an injury, but I would take this information and try and get more important stuff from them.
Okay. Does it matter what kind of trainers the runners wear, though? Because in running stores, they sell you shoes based on the foot type. What are your thoughts on that?
Yeah, again, many thoughts. So a bit of history behind this. The stuff that you've just mentioned, trainer prescription based on the foot type. The history is that if you have normal height arch, most people get recommended what's known as stability in trainers. If you have really pronated feet, then you get recommended what's known as motion control trainers. And if you've got really high arch or high arches, then you get recommended what's known as cushioned trainers. So that's the history. Unfortunately, though, if you look at as to whether this actually prevents running-related injuries, there is very little evidence to prove that it does. And I'll quote another study here, a study that was done by NAPIC, and that's NAPIC with a K, in 2014 in 6,000 military recruits. So they had two groups in the study. The experimental group was the group where they fitted trainers based on the description that I just gave you. So that's 3 different types of trainers based on the foot type. So that was the experimental group. And in the control group, they fitted everybody with just standard trainers. And they wanted to look at injury occurrence over a whole time frame, over a whole season. They actually found that both groups, so that's the experimental group and the control group, presented with equal number of injuries towards the end of whenever the study concluded. So there was no real difference in injury rate when you prescribe trainers on this basis. So it's a little bit difficult to recommend trainers based on foot type. This study, although I've mentioned it, is not the only one. There's loads of studies that have done the same kind of work and have come up with the same sort of conclusion. There is only one particular study that again I will quote by another group. The lead author was Mali Su in 2016, and what they found was that people who have more pronated feet may benefit from being prescribed motion control trainers. So this was based on the fact that in that study, people with more pronated feet who were given standard trainers reported twice the rate of injuries, and hence their recommendation. That's the only study that gave us that kind of conclusive information. The rest of them basically haven't showed any changes in injury rates. Now, even if you look at various types of trainers, whether you think about high stack trainers, low stack trainers, the key here is if you change somebody's trainer, you will shift the load from one place to the other. So if you give somebody who's been wearing a high stack trainer, if you put them in a minimalist trainer, or that's minimalist based on the amount of cushioning that the trainer provides, you're just shifting the load from more proximal parts, so from the knee towards the ankle. Okay, so that's important to sort of remember and know. But if you think about a prescription of trainers based on foot type, there just isn't the evidence out there to support that.
Okay, that's interesting. What you've talked about is injury prevention. So, what about rehabilitation? Would you consider changing trainers during rehab?
Yeah, that's probably the point where I would think about shoe trainers more than I would in terms of injury prevention. So I'll give you an example. So if I'm treating, let's say, a runner, an experienced runner with long-term patellofemoral joint pain, and let's say they have been using either standard trainers or high stack trainers, and in those sort of scenarios, what we know is that with high stack trainers in particular, a lot of the loads are absorbed around the knee region. Now we know that with patellofemoral joint pain, that's kind of what we don't want. So what we could consider is transitioning that individual to a more minimalist pair of trainers, and that would mean that the cushioning is far less than a high stack pair of trainers. So in that sort of scenario, you're shifting the load from around the knee area to the lower leg, the foot region. A couple of things might happen though. So when you shift load from one area to the other, you're obviously imposing more load in that area. So for instance, when you put somebody in a more minimalist pair of trainers, it appears that their foot strike pattern changes to more of a forefoot strike pattern. Now, given that this change happens, we need to make sure that we've prepared that individual with appropriate strengthening exercises for the calf muscle in particular, because that will be able to absorb some of the forces coming through. Because if not, then we're talking about a sudden change in load and shifting it to another area, and that increases tibial loads if your calf muscle isn't quite prepared for that, and then you might be exposing that individual to another injury. So and there are certain scenarios like that where you could consider a change in trainers, but also be aware that if you're transitioning, particularly if you're transitioning them into minimalist trainers, do that over a 6-month period, and that's generally what's recommended. And the other thing is make sure that you prepare that individual with appropriate strength training, in this instance more calf-based training, so they're able to absorb those loads better.
Okay, so do you have an order of importance as to what contributes the most to running-related injuries?
See, from my practice, I would say that most injuries and the cause for most injuries appear to be errors in their training loads. So things like too much too soon, they've tried to increase the mileage too much, or they've thrown in too much speed work in the recent past. And these things can expose one to injuries. So training loads and training errors takes the biggest chunk of importance in my order of importance. The next thing for me would be tissue capacity and biomechanics. So when I say tissue capacity, I'm referring to muscle capacity, and in that region, I'm thinking about muscle endurance as well as muscle peak force capacity. So I would need to assess both those elements rather than just think about a muscle as one entity. And in terms of bone health, I'm thinking about bone mineral density. And are there any indications in that individual of reduced bone mineral density? Either have they had previous bone stress injuries, as we already discussed, that seems to increase the chances of bone stress injuries or reoccurrence of bone stress injuries. But also, are there other indications? So things like a very low BMI, for instance, and that could also be an indicator to altered or lowered bone mineral density. So those are a couple of things in terms of tissue capacity. And when I mentioned biomechanics, in this context, what I'm referring to is a running assessment, running gait assessment. And one person that I've looked up to for this over the last several years is Dr. Rich Willie from Montana Running Lab in the States, and he's done a PhD in running biomechanics, and then I've got some fantastic information from him over the years, and I've learned a lot from him. So when I say biomechanics, that's what I'm referring to.
Right. So you've mentioned bone and muscle capacity, but what about tendon capacity?
Good point. Now, if they've got lower tendon capacity, they'll be presenting to you with tendon pain or tendinopathy, right? So if they're presenting to you with, let's say, Achilles tendon pain, you know that the capacity of that tendon is lowered. So you don't necessarily need to think about how you would assess that. Hi guys, I hope you're enjoying the podcast so far. We've covered a few important things already. In the next part, we're going to be looking at gait analysis, gait retraining, rehabilitation of a runner, and looking at training plans as well. I hope you enjoy the rest of it.
In terms of assessing gait, is a treadmill-based assessment enough, or would one need to assess running gait outdoors?
If we're talking about running biomechanics and assessing running gait, treadmill-based assessment is generally considered a valid way of assessing running gait. Certainly, all the research papers that we read of have been based on treadmill assessments. It's generally considered by most experts and most research around the world that treadmill-based assessment for running gait analysis is great.
Right. So, apart from the treadmill, what other kit does one need to do this assessment?
Okay, so first point is what we're talking about is two-dimensional gait analysis. The difference here is when you read most research papers, they use 3D assessment tools, which in clinic is quite difficult to find and very expensive. So we stick with 2D gait analysis. In terms of what kit we need something that you can film the running gait, because it's quite difficult to assess a runner live on a treadmill. You need to be able to slow things down. So you need some kind of a camera. So in practice, I use a high-speed camera, which allows me to film at 120 or 240 frames per second. But you don't necessarily need to invest in one. You could use your mobile phone device or a tablet device, and most of the newer devices allow you to film at better than 60 frames per second, which is what you need in this scenario, because if it's more like 30 frames per second, you will find that it skips a lot, or if you want to freeze a frame, the picture won't particularly be clear. So you need something that films at better than 60 frames per second. I think that's pretty much all that you need.
Okay, and how many views do you record to be able to analyze running gait?
Okay, so we need what's known as orthogonal views. So two views at right angles to each other. So one to assess coronal plane, kinetics, kinematics, as well as one to assess sagittal view, kinematics. And also, there is this particular thing called perspective error, which means that if you are filming a particular joint, or you're trying to analyze, let's say, one particular joint, try and keep the camera at that level and move it appropriately. So let's say you start filming from the hip level, drop down to the knee level, and then drop down to the foot level. And if you try and get about 7 to 10 steps at each of these levels, that will be sufficient. And do the same when you do a sagittal filming as well.
So once you've completed the filming process, what do you do next? Can you talk us through that, please?
Okay, so the first thing I do is I'll probably say to the patient that I've filmed this, and I didn't mention one thing previously, so I should have mentioned that I would also measure the runner's cadence manually. So literally count the number of times their right foot hits the treadmill in a minute, and I would double it, and that would be the cadence, which is the step rate per minute, and that's important. That's an important thing to measure as well. We'll come back to that later. But coming back to your question about analysis, my point here would be that I would probably tell the runner that I will analyze it and feed information back to them, or the relevant information back to them when I see them next time, because otherwise you're trying to sort of analyze the gait in front of the runner, and it's quite difficult, particularly when you're learning. And the specifics of assessment, what I will do, or analysis rather, what I would do is I would start, let's say, distally, and then move up a level at a time, and that gets you into the habit of just doing the same thing every single time, and that you have a systematic approach towards it. I'd start at the foot level. I'd look at foot strike. I would look at then looking at the position of the knees. Is there any space between the knees during mid stance as one leg crosses the other? I would also look at things like contralateral pelvic drop and femoral adduction. So these things I would look at from a coronal plane perspective. Now, if you think about the sagittal plane, I'm looking at things like, again, let's start with a foot strike. And if there's a high degree of ankle dorsiflexion during foot strike, and also the tibial line, as in is the tibia vertical or is it more inclined? Because these things could represent an overstride pattern where the foot is landing a long way in front of the center of mass.
Right. So it sounds like you're looking at quite a few things. But can you give us an example of what abnormal biomechanics do you commonly see?
So a few things I mentioned previously. So, for example, if we're talking about the coronal view, the kind of things that you may see are things like increased contralateral pelvic drop and increased femoral adduction. And these things are very common in patellofemoral joint pain in particular, although they can be seen in other conditions as well. So those things you can look at. You can also look at things like the step width. And if the step width is really narrow, that seems to increase more stress and load on the tibia and as well as the ITB. So it can be condition specific, but generally at this stage, you're looking at these kind of abnormalities. And if you shift to the sagittal view, again, we spoke briefly about the combined ankle dorsiflexion angle increased with a tibial line inclined, which then would represent an overstride pattern. So yes, these are a few examples that I can mention when you're talking about abnormalities that you commonly would see when you're analyzing somebody's.
Presumably, these abnormal biomechanics can be retrained. Otherwise, there wouldn't be a point in assessing them.
No, you're right, Bhavna, yes. In fact, gait retraining can be a very useful adjunct in treating a runner. It certainly it helps keep them in play, and although you need to consider other treatment modalities in completing the rehabilitation, gait retraining is a useful adjunct, yes.
So can you give us an example of what you would do in gait retraining?
Yes. If we stick with the example of the patellofemoral joint pain, there was a really good paper published last week which looked at increasing cadence of runners or in runners with patellofemoral joint pain. So just briefly mentioning what I previously mentioned, forgive me for the repetitiveness. So things like femoral adduction increases and contralateral pelvic drop also increases, and this is exactly what the study found. And these were in about 10 runners with patellofemoral joint pain. And what they did was they increased their running cadence by 10%. By doing this, they actually found that not only did these measurements reduce, so the contralateral pelvic drop and the femoral adduction, but it also resulted in a reduction in patellofemoral joint pain, and these runners were able to increase the running mileage over a 3-month time frame as well. So that was one study. That's probably the most recent study, but previous studies have also done similar things. So increasing running cadence anywhere between 5 to 10% appears to have a big impact on kinematics and as well as patellofemoral joint pain.
Great, but how easy is it to change the cadence?
Yes, it is fairly easy actually. Again, if we stick to the similar example, what I would do is I would use something like a metronome, which you can, you can download a free metronome on your smartphone device and use that, and you could set that at a certain number. So if I give you an example of, let's say, a runner who has a cadence, a natural cadence of 150. What you could do is a 10% increase on that is 165. So you could set the metronome at 165 and ask the runner to coordinate the foot strike to each one of those beats. Okay, so that's a simple way of increasing running cadence. There is another way as well, which is slightly more expensive. So you could ask runners with GPS devices, depending on which GPS device they have. So for example, like a Garmin watch or a Sunto watch, they make their own foot pods, which sync with the watch, and then you can set the watch at a certain cadence. So again, let's say 165, and in that instance, it gives the runner real-time feedback on their current cadence, and if it's too low, then the runner can automatically try and increase that. But that's a slightly more expensive way, because footpods cost money, so do GPS watches. So you could just use a metronome just as easy.
That sounds great, Arun. So you said this would only ever be an adjunct. So what about other modalities do you think that are essential in rehabilitating a runner?
Right. So we address biomechanics with Gait retraining, as we spoke about. If you're addressing muscle capacity, we need to recommend the right exercises to strengthen muscle capacity at the right intensity. That's where we often go wrong. So for example, strength gains in quadriceps or calf muscles or gluteal muscles, we need to sort of recommend at the intensity of about 8 repetition max and 10 repetition max, and maybe slowly moving down closer to 6 repetition max over a period of time. So these things are important, and that addresses muscle capacity. When it comes to tendon and tendon rehabilitation, we need to remember that the tendons have a unique function, and that's the energy storage and release function. So when you take into account tendon rehabilitation, you can certainly start with heavy, slow resistance training, but then you have to move into that plyometric training zone as well. The main reason for that is when you put somebody through a heavy, slow resistance training program, let's say, for example, when you're rehabilitating a Achilles tendon pain, you will load the Achilles tendon to about 3 times your body weight. But when you get somebody to run, the amount of load that goes through the Achilles tendon is 8 times the body weight. So you're kind of not really rehabilitating that individual to the full capacity. And that's why when you rehabilitate tendon, in fact, when you rehabilitate any runner, to incorporate plyometrics at the appropriate time frame is really important. And in particular, when you're rehabilitating a tendon. And the last thing I would say is addressing bone health. And this is a little bit more complicated because once you've deciphered that there is a bone density or bone mineral density issue in this individual, we probably need a multidisciplinary approach. And what I mean by that is they obviously need to see a dietitian to check whether there are problems with their energy intake, as in their food intake. They may even need more blood tests to look at hormonal levels and such like things. So, you need to get their general practitioner or general physician involved. If you're treating somebody in a slightly more sporting environment, then you'll have a sports medicine doctor. So that needs a slightly more, multidisciplinary approach.
That's brilliant, Arun. That gives me a very good insight into rehabilitation. However, what about training, loads, and plan? Can you tell us something about that, please?
Yeah, we can. If we take the example of a marathon training plan, they span over 3 months, 4 months, or 5 months. Now, first thing I'd say is if you're talking to a novice runner, it would make sense for them to pick the longest plan, because that would mean that there will be the most gradual increase in mileage. Now, that's an obvious thing to say, but that's important. The other thing to be clear about as well is in terms of training loads, you can also discuss speed. A lot of the runners that I commonly see tend to get into this trap of running at the same speed all the time. So what they refer to as their tempo pace or threshold pace. And that means that there's a big chance of overtraining because they're constantly pushing themselves beyond the point where they need to push themselves. What I often recommend these days is what's known as polarized training, which is an 80-20 model, which basically means that 80% of the training volume, so that is the time that they run for, needs to be done at low intensity, which is less than 75% of their maximal heart rate. And the rest of the 20% in the 80-20 can be performed at a high intensity, so more like 90-95%. So you kind of try and avoid that middle zone, that threshold zone, as they call it. One of the people that I've followed in this context, his name is Dr. Steven Seiler. So he's done a lot of work in elite athletes, and certainly you can apply lots of those principles to the recreational runners that most of us treat. And the other resource that I should mention is there's also a book called 80-20 Running, and this was written by Matt Fitzgerald, and that's a good resource to read as well if you want to know more about this polarized training model. The only other thing I would say as well is if you're trying to follow a training plan over 5 months, that's an awfully long time. I would try and break things down into 4-week chunks, and try and change things around gradually in that time frame, so they don't get too bored with the whole plan. So that's what I'm referring to when I say a training plan. I'm trying to sort of give them as much information as we possibly can in that context as well.
That's brilliant, Arun. Well, I'd like to carry on talking about this stuff, but I must draw this to an end. Thank you so much for sharing all this information and your wisdom. I'm sure people listening will really appreciate it. However, I must ask you about your course again. So when are you planning to teach it again in India? Are you looking at teaching in any other cities apart from Pune?
Yes, I am, and I certainly will talk to anybody who wants to talk to me about running. The more the better. Look, when I finished off in Pune last time, I was thrilled with the interest and the feedback that I had, and certainly I was already looking forward to the next time, and this was last month. So I need to sit down with Rahul and chalk out a plan and try and put something in the diary. Certainly at some point next year, I certainly intend to do the course in Pune, but I also want to try and look at other cities because running has become so big in India now, and most cities have their own marathons and other running events. So absolutely, yes. In fact, I taught my course Treating a Runner here in the UK last Saturday, and that also went down a treat and had some amazing feedback. So onwards and upwards, and I certainly want to try and do this more often.
That's brilliant, Arun. Thank you so much for talking to us.
Thank you very much, Bhavna. Hope you guys enjoy this podcast. Thank you.